seen at, let me acknowledge that we're being recorded here. Okay. He is a 46-year-old man who worked as a coal miner until about 2 years ago, 1 or 2 years ago, when he became disabled by problems with his breathing. And I'm going to use vague descriptive language rather than precise diagnostic language, because this is a case where we don't have a certain precise diagnosis, but we have the clinical presentation and the patient's account of how he became so fully disabled. So if you scroll down, Krista, to the, or Mitra, to the history part. Okay, so a 46-year-old white male came to see me and Lisa Emery at New River Breathing Center in probably November of 2021. And he came, as many of our patients do, asking for assistance to file for state occupational pneumoconiosis benefits, or what we call an OP claim, occupational pneumoconiosis. He gave a history of exertional dyspnea that developed after 22 years working on a prep plant. And so he didn't work underground, but many of you know, and for those who don't, prep plants can be extremely dusty, even though they're not underground, just as drilling on the surface can be extremely dusty, especially with silica dust. He got laid off in October 2018. I think it was an economic layoff. But just a few months later, he was hospitalized for 13 days at ARH Hospital in Beckley with severe shortness of breath and lung congestion. He was sent home on oxygen and medication. His primary care provider continued his care. He didn't get better over that winter of 2018-2019, and in July, he was admitted to Charleston Area Medical Center, and that admission lasted for 19 days. At neither one of these admissions was he intubated or on a ventilator. But after being discharged from CAMC in July of 2019, he continued having shortness of breath, hypoxemia by his pulse ox reports at home. And during that hospitalization, he reports a lot of testing by various specialists. He was discharged to the Asthma and Allergy Center in Beckley, and he went and was followed by them, but later they terminated his care because he was there one day and refused transfer to a hospital by ambulance because they noted that his O2 sats there were 74%. And Mary, I would say to you that this is an illness narrative that just simply doesn't fit into the standard categories that the system maintains and allows. In June of last year, he established care with a New River physician and has been followed there since then. But when I say him, had only one office visit. He reported severe shortness of breath, MMRC 3 to 4 levels. One of the really difficult things for me when I saw him, and I wasn't seeing him to assume his care, I was just seeing him to kind of sign his papers for occupational pneumoconiosis so he could file. But naturally, when you see somebody like this, you're curious and you want to help the person because he seems like he's struggling. And so one of my questions was, well, did this happen all of a sudden, or did this happen gradually? Was this a sudden onset or gradual onset? And he had a difficult time answering that question. And I'll just jump ahead and say at the end of the visit, there was quite a bit of disagreement between me and the respiratory therapist, Lisa Emery, my real strong partner there, about whether this really was occupational pneumoconiosis or something else. And that's a chronic disagreement that can arise between clinicians and benefits counselors. And it made us look at he had had federal black lung testing at Cabin Creek a few months before, and so it made us go and look at that. Carl, I see you're here now. So I was able to find the federal black lung testing, and Carl will comment on that in a minute. So he had not previously applied for OP benefits. He had just applied for Social Security disability benefits based on his breathing. There was nothing remarkable in terms of other comorbidities in his past medical history. He wasn't on any major medicines except for breathing, and he had been vaccinated for COVID-19, which around here in West Virginia kind of sorts him into a particular cultural category. There's not just 2 categories, there's probably 6, but he had chosen to have COVID-19 testing. On physical exam, he was alert, well hydrated. He had portable oxygen with him. His vital signs were, as noted, blood pressure 141/82, sat 93% on room air, heart rate 124. He had, to me, he was one of those people you listen to his lungs and he's kind of got bronchi diffusely over all lung fields on both inspiration and expiration. Hard to say about any crackles or rubs. He had no scars on his lungs like from previous thoracotomies or tracheotomies or chest tubes. Heart unremarkable, extremities unremarkable, except his hands were kind of dusty gray. And I asked him about that and he said, well, he does sharpening of tools in his garage. Neurologic unremarkable, except for marked anxiety. We had one chest x-ray on him that was a B-reader chest x-ray, and it was normal, both for pneumoconiosis and in general for other heart and lung findings. His PFTs, which I'll show you in a second, I'm sorry we don't have the full image, and I might be able to get it while Carl is talking. Our PFTs showed severe obstruction, and the values are up above in this form, but and you can go up there.
I have the image, Dan, if you want me to show it.
Okay, great. If you mean our image?
I have the image that you sent me, yes.
Okay, great. Why don't you put that up? Thanks. So you're gonna have to let him share, Mitra.
Sure, absolutely. Let me stop screen share. Dr. Wertz, I'll make you co-host so that way you can share your screen and pull that up.
Okay.
So since you've got it, Carl, I'll let you go ahead and describe it.
We have one more, sorry. I was ready to do mine. So these are the results you had from New River Health. And let me make that bigger so that the weirdness goes away. Okay, there you go. So I'll let you talk about them, but
one thing that's missing on these is the technician's description, which Dr. Weissman and our NIH training has taught us to look for, and that is the technician's description of acceptability and repeatability of these results. And this was a technically good test that was acceptable and reproducible. Go ahead, Carl.
This is a testing. So the testing, I didn't know with the dating. So is this was done after we saw them here for?
Yes, this was done in November 2021. Okay,
so you can see this on this gentleman. This gentleman has his FVC is below normal, 71% predicted. FEV1 is markedly reduced at 33% predicted, and the ratio is 0.36 or 36%. Which is a crazy low ratio. He also has low lung volumes and not an elevated residual volume. And the DLCO is actually fairly normal in this testing. And you can see he's got this, if you look down here at the bottom, you can see he's got the scooped out flow volume loops that you can see on the bottom of this picture. And this is the testing at New River in November, okay? And I'll go on, come on, screen advance, there we go. This is the testing we had at Cabin Creek, which I think predated this.
Yeah, I think so too.
Which is pretty normal. The FVC was 98% predicted, FEV1 was 85% predicted. He had normal lung capacity a normal residual volume. The DLCO was normal. So there's something happened.
He has a ratio, his ratio is 69.
His ratio is 69, which is still above the lower limit of normal. So it's a normal ratio. But this testing is normal. And just for completeness, because everybody wants to see them, there are the graphs. So interestingly, it is really not a scooped out flow volume loop. And there's no particular abnormalities that you can see on the volume time curve.
Carl, do you have the date on this?
On I can
yours.
figure out, if give me a second, I can figure out the date because I just did that. I just put those together.
Because these dates are kind of crucial here. I'm gonna go find the date on the one that we did, so we'll have that.
I'm doing the same thing. So this was done on 11/3 of 2021.
Okay. Thanks.
And I'll go back to the. I'll go back to there where it's de-identified.
Thank you so much, Dr. Woods.
I made up one more that was just, now I compare them side by side.
Awesome. No, that looks great here. And let me know if I can also pull up the case again at any point. But we can definitely go into any discussion that everyone has.
Well, one more part of this presentation, and I was stepped away for a second to look for a password. If you can go back to the case, Mitra.
Okay, I'll stop sharing then.
Yeah.
Okay, let me pull up the case.
If you go to the bottom, is what are the questions? What are the questions that when we present a case, we come to the hub and the group with questions. And so at the bottom here were my and our main questions. What's the differential diagnosis for this? What, from our perspective, given how the patient sat in front of us and what his lung sounds were and what his story was and what our PFT show, he seemed to have a rapid onset disabling lung disease. And he described spending 19 days in the hospital in the summer of 2019, I think it was, at CAMC. Now, a crucial piece of data here should be, what did that discharge summary show? And I'm not sure we have that. And while we're talking, I'm going to look for it. So then for us, it would be, so what's the differential diagnosis? I had invited his PCP to be with us today, but he wasn't able to make it because I hoped that he would hear this, because he's the person kind of who's charged with accompanying this person on this illness right now. So if I were the PCP, what additional tests would I be doing to try to sort this out and figure this out? And there was a crucial additional test I did do that I'll tell you in a second. And Mary, this will resonate most for you. Another question is his current treatment optimal for him, or is there something missing in his treatment? And then, is he permanently and totally disabled due to his lung condition? I mean, we got a normal spirometry in October, and then we got this profoundly abnormal spirometry and person who presents as dramatically impaired. And so that's kind of a conundrum or a paradox that we're struggling with. So it takes you kind of back to what's the differential diagnosis. The additional tests that I did after a long conversation with my respiratory therapist about why I wouldn't sign his OP form, and was being very pressured to do so, and was being questioned as to kind of both my compassion and my clinical acumen. But I stood firm and wouldn't sign it. Was this really rapid onset, or was this actually more of a prolonged onset? So the test I did was to ask him to write a letter or write a story of how this had occurred over the years. And the therapist had been saying to me, this guy's not kind of all there. He's inconsistent. He seems confused. And so I asked him to go home and with his wife to write a letter. And about a week later, a 4-page, very neatly written letter came in that was a very poignant history, pretty amazing to read, which described a long gradual onset that the wife had observed. So those are the questions that I bring and we bring to the group.
Thank you so much, Dr. Doyle. Great case presentation as always. Let's see. So we have a couple chats here.
It's great that Brandy's here, and I see your questions, Brandy.
Yeah, thank
And
you so much, Brandy.
we're gonna look on. I'm gonna find those. I'm gonna find the dates of the two. I'm gonna work on finding the dates right now of those two of RPFT.
Awesome. Thank you so much for checking in on that for the question there. While we get to Brandy's question in the chat, did anyone else have any maybe clarifying questions or comments to ask Dr. Doyle or Dr. Wertz? And please feel free to unmute and chime in or just chat in, and I'm happy to read it out loud.
Okay, again, my clarification, which in some ways adds to the paradox rather than reduces it, is that our PFT was done on July 20th, 7/20/21, and yours again, Carl, was when?
11/3/21. So he got better for some reason.
Yeah, and then I saw him after that when he was looking so bad. And actually the date of that visit when I saw him was December 20th, 12/20/21. And the X-ray, Brandy, the date of the X-ray, which is relevant for everybody, was September 13th. So it was between the two spirometries. Okay, so that's the timeline. Our bad spirometry 7/20/21, normal chest X-ray 9/13/21, good spirometry at Cabin Creek 11/3/21, sees me on 12/20/21. And by the way, there have been there was a follow-up visit with the primary care provider on January 10th. And at that visit, which seems to have been a routine follow-up visit, it says that he's continuing to have shortness of breath, orthopnea, chest X-ray looks okay. And the diet, he had that tachycardia again. The primary care provider apparently does have the hospital records and mentions a diastolic dysfunction on echo. And his diagnoses that visit were COPD, severe persistent asthma, hypoxemia, tachycardia, diastolic dysfunction, multiple joint pain, and nothing since.
Yeah, when I saw him in November 3rd last year, he was 2021. He did 8.4 METs on the treadmill with blood gases suggesting he could sustain that or maybe even a little bit more exercise on that day. So the question is, what does he have that's cyclical or that's coming and going? And my first thought was is COVID, did he COVIDize in here someplace? But this sounds like something more different than that. Maybe some CHF, but that shouldn't cause obstructive disease, which is what he has. And I wonder if there's like an upper airway thing. Like, does he have a thyroid mass or something like that? I mean, I'm guessing right now because I don't know. And asthma, I guess plain old ordinary asthma could do that too, right? Because it comes and goes.
We had a couple more questions coming through as well, asking about some clinical things and then Mary was wondering as well if you can describe more about what the letter told you about the onset of his disease and how it shaped your final decision. Great question. Thank you, Mary.
Right, and a couple questions I saw flash by. One was, Grace Ann, has he had a CT? My guess is probably yes at CAMC in July 2019. I know we should have that right here, but so far we don't. And then Brandy asked, is he actually taking his meds? And of course, it's hard to ever know that for sure, but I think the answer is yes. And to Mary's question, there's kind of, because the letter is so long and so poignant, but your specific question about the letter was about the gradual onset or rapid onset, and the letter describes gradual onset. You have to understand that subjectively, their purpose in writing that letter was to demonstrate gradual onset, so he was a candidate for OP benefits. So that obviously influenced how they told the story. But their story was gradual onset, long gradual onset, which would be typical for OP, versus the episodic kind of illness that Carl's talking about, which could be asthma.
And he could have more than one thing going on. And Grace Ann asked the question also, has he had CT imaging or something like that? And if he was hospitalized for over 2 weeks with respiratory complaints, I'm confident he had a CT scan. I'm not sure we know the results.
Yeah, I agree.
So this remains a mystery.
It looks to me, I'm looking here, CAMC, what I have from CAMC, we do have a discharge summary from CAMC now in the New River record. And it's interesting, the primary discharge diagnosis, and there's is acute exacerbation asthma. There's a list of secondary diagnoses. I'll go through them quickly. Grade 2 diastolic dysfunction, hypertension, weight loss, abnormal TSH. That's pretty interesting. Tobacco use, sinus tachycardia, THC use. And I think he is a habitual THC user, so you could speculate about a toxic batch and what that might have done. Because we're pre-legal, at that point, we're pre-dispensed medical marijuana in the state. So it was getting it through, non-established sources. They did bronchoalveolar lavage, CT of chest, chest x-ray, no acute process, CT of chest, impression, no evidence for pulmonary embolus, small amount scarring atelectasis at the basis, no infiltrates or edema or effusions or findings of pulmonary fibrosis. Resolution of peri-hilar ground glass opacities, which that takes us, back to your COVID question, Carl. And then the narrative is patient admitted with worsening dyspnea and wheezing. He was diagnosed with acute exacerbation of asthma, but also evaluated for eosinophilic pneumonia and Churg-Strauss, which were ultimately ruled out. But he came in to me telling me that they had diagnosed him with eosinophilic pneumonia. So the discharge summary says that was ruled out. He comes away thinking he has it. Symptoms improved with nebulizer treatment and steroids. Bronchoscopy performed inconclusive. Echo obtained. Patient was found to have grade 2 diastolic dysfunction. Discharged hemodynamically stable. So that's what came of a 19, let me see if it really was 19 days. Admit 7/5, discharge 7/17, so actually 12 days. That's a long time to be in the hospital for asthma. And so that the doctors were struggling trying to figure it out while he was there.
Thank you so much for the clarifications, Dr. Doyle. We are about halfway through the session now, so I wanted to maybe pull up the case again to go over those questions, maybe if anyone had some feedback or recommendations or responses to them.
David, you're the only pulmonologist with us today. I'm missing our other pulmonologists, but what are you thinking?
Yeah, I'm back online again. I'm sorry to step away for a minute. I had a repairman here. And I agree that that it would be hard to, pin this on pneumoconiosis, right? I mean, in terms of compensation, what coal mine dust does is it causes COPD, it causes emphysema, but you didn't see that on the CT scan. It also causes, interstitial lung disease, but you didn't see that on the CT scan. I was wondering, since they were entertaining the diagnosis of eosinophilic pneumonia in Church-Strauss, do you have like a percent eosinophils on a CBC or an eosinophil count or a serum? Do you have a serum IgE?
We do have a CBC with an eosinophil count. I think it just got done at the recent, or actually, I think I did it that day that I saw him. White count 9,000, 5% EOs. So there you go. You're right on the borderline.
Okay. And do you know if he ever had a serum IgE?
I do not know that, and I don't see that in the lab work in his record for New River.
Yeah, I mean, the reason I was asking about that was from the standpoint of like ABPA, like allergic bronchopulmonary aspergillosis. It will often have like a really high serum IgE. His lung function, before I got pulled away, his lung function looked like it was a complex, thing, because he was clearly obstructed, but it looked like he also had an element of restriction there too. So it's a complicated case. But the with the peri-hilar, infiltrates, I mean, you wonder about, some other process. So I think it's a tough case. I think it'll become clearer, as time goes by, but I have to say that I agree with him not really being a pneumoconiosis case. This is more complicated than that.
Thank you.
Thank you so much, Dr. Weissman.
Anybody else?
Anyone else with any comments or thoughts about this case?
Thanks for helping us think about this, you guys. It's a like I said, a paradox, a conundrum, and all the while the guy is suffering, and you feel for him.
Absolutely. And Dr. Doyle, were there any other comments or questions you wanted to go over about this case?
No, thank you.
Awesome. Well, thank you so much again for the case presentation. Again, it brought some great discussion here and posed some really great questions. So we really appreciate it. Dr. Werntz, we can go into your didactic now. If you would like to share it on your end to advance, you're more than welcome to. And I'll just turn things to you now. I believe you are still muted.
Okay, so I think you should have video and hopefully now audio. And what we're going to talk about today is what do you do with, how do you adjust spirometry or lung function tests in people who have anatomic abnormalities? If you think about it, this is something that came out of the black lung stuff that I do, because when you do a bunch of them, sooner or later somebody's come in that's had a lobectomy or a pneumonectomy, or they're transgendered, or they're markedly obese or whatever. And so I kind of figure out how to deal with these I do them one at a time, but I've kind of kept track of them. So we're going to talk about a couple of them today. There's more, so we can do some of these later, but we'll get started today. And come on. So first case I want to talk about is a lobectomy. So this is somebody who's had a surgical lobectomy for whatever reason. And we'll start out with kind of a case. So this is somebody who comes in. All these cases are black lung cases because that's where all my cases come from right now. And so he has an FEC of 65% predicted, an FEV1 of 57% predicted, The ratio is 63%. And if you look down below, the total lung capacity is about 82% predicted. And I kind of blew this up a little bit so we can see it a little bit better just for the spirometry and the lung volumes. This is the same information we just saw. Here are the curves because you can't have spirometry without curves. And a little scooped out maybe on the top, but and a little bit of prolonged expiratory phase before it reaches a plateau on the time volume curves on the bottom. So I went back into, when this happened, when I saw this patient, I went back into the medical literature. My question was, what's the impact of having had a lobectomy on spirometry results? Found a couple of studies. Dracu and Kim found that there to be about a 15% decrease. So if you look at the Dracu was 15.4 for FEV1 and Kim was 15.6, they're the same. I got 14.2 versus percent decrease on the FVC for Dracu. Kim did not measure FVC, they only did FEV1s. Later study, and these guys were mostly trying to show how much better video-assisted thoracic surgery was from open thoracic surgery. But when they did theirs, they found about a 20%, 19% decrease in FVC, 21% decrease in FEV1. And doing something mediastinal without controls, without lung resection was their control, which had about a 5% impact. So I kind of suspect that the number is really 15% of the decrease in both FEV1 and FVC that we would expect to see. So there should be, there's an impact if you do lobectomy on FVC and total lung capacity. There shouldn't be an impact on the ratio though. That should remain, because it should not affect airway function. And the FEV1 decrease should parallel the FVC decrease, which is saying the same thing the other way around. Literature shows there's about a 15% decrease following lobectomy, and it doesn't seem to matter what lobe was removed. So the thing for clinical use is expect to decrease FVC. Ratio should stay the same. 15 or 20%. If you want to be conservative, you can use 20%. If you want to be less conservative, you can use 15% as the change number. And don't, if you're gonna do corrections, you can fix the FVC and FEV1. Do not fix the ratio. Hang on one second. I have a clinical question. I'll be right back with you guys. Sorry about that. So this is kind of how I did the math. What I do, my preference is to leave their numbers alone and adjust the expecteds. So adjust both the lower limit of normal and the predicted. And so if you're going to use a 20% correction for this guy, so his predicted was 4.11 liters times 80% or 20% less. I get 3.29 liters. Do the same thing for the lower limit of normal, where I just multiply what's there times 80%. And then you compare his new numbers with his current. So I now would expect him to have a 2.68 liter. Wait a minute, where am I at here? His FVC was 2.68 liters. I think that I would expect him to have 3.29, but the lower limit of normal is 2.74. So he's still below the lower limit of normal. This is still restrictive disease, even though I've adjusted the lower limit of normal. And do the same thing for the FEV1% predicted to calculate the severity. So I would still call this a mild restrictive pattern. But that's what I have taken to doing this and dealing with people who have had a lobectomy. And as I said, it doesn't matter what lobe was taken out. The math always seems to be the same. Oh, come on, get back on that screen. Now, next case, this is one that is becoming more of an issue. And I'm now reflecting, these are recommendations soon to be published, but not currently published recommendations for how you would address this sort of a scenario. So this is a set of spirometry results. The person came in, they are 33 years old. They appear male, they were put in as male Caucasian, and the computer determined that they had mild restrictive impairment because of the FVC below the lower limit of normal and a normal ratio. So they said that's the normal restrictive pattern. Can you guys see that, or is this box in the way? Can you see what's on the right-hand edge of the screen?
Yes, we can see that.
There we go. So your nurse comes in and mentions that the patient says that they were a transgendered man. We'd put them in the system as male and called it restrictive disease. So the question is, how do you correct for this? Transgender population, these are the last numbers I could find, was 2016. It's a bit less than 1% of the population, probably. So I'm going to get into definitions, and I'm going to try really hard to use these vocabulary exactly correctly, and I will probably make a mistake, and I'm sorry, I'm not trying to offend anybody. So gender or gender identity is an internal sense of being male, female, or another gender. Gender expression is how the person appears and expresses that gender. Sex is male, female, or intersex based on physical characteristics. They used to use the term biological sex for that. Now they're using the term sex assigned at birth. And transgender is somebody whose sex assigned at birth and gender identity do not correspond in the expected way. To date, every spirometry equation we have uses gender or sex as a key determinant for the predicted equations. So the problem is, if you incorrectly use the male predicted equations, you can show restrictive disease, because all the male predicted equations for the same height and age are larger than female. Incorrectly using the female predictive equations may miss disease in a male. So ATS's current recommendation is to use birth sex for spirometry. And for people who had gender affirming medical steps only done as adults, this is probably an adequate approach. And so if they had the hormonal treatment only after puberty, this is probably fine. The problem is that it doesn't work for people who had gender affirming care prior to or at the time of puberty. So what you have to do is ask some questions. And the key question you're trying to get to is, what was the hormonal status as they went through puberty? And so if you have somebody who was a male at birth and they were using estrogen at puberty, you'd expect them to have smaller, in quotes, female lungs. And if they were receiving testosterone at that time, you'd expect larger male lungs. There are no specific equations for transgender people, and I suspect there probably never will be, because it's too variable. One of the things to keep in mind is that many youth will delay puberty with medication. But the key question is, what was their hormonal status when they went through puberty? Current hormonal status is less important, and patient without any hormonal treatment. So if it's just just an appearance difference but no hormonal treatment, you should use the sex assigned at birth, because it's the hormones that change the lung size, not their appearance. So you have to talk to the patient. They say they're a transgender man, and they said they started hormonal therapy after puberty. So the right thing to do for this patient, in our example, is you need to compare them to the female normal equations. Then you have to the trick is get your staff, or if you're running the machine, reprint the results with a gender set to female, which will get you the right medical answer. So they rerun the report, put it in as female, and the person has normal expiratory flows. This is our example case. But we still have a problem. And we have the problem of confidentiality. Some people who are transgender are absolutely out, open, and everybody knows they're transgender. That's their identity. And then they're not going to care about this. But that's not true of everybody. So the problem is, if you're seeing this and in a setting where somebody else might look at it, if you're doing pre-employment work or surveillance work for an employee that's working wherever in the mines or whatever they're doing, and they present as male, and the employer thinks that they're male, and you send a result that says they're female, that could be a problem. That can present, that can cause problems for that worker. And so you have to be mindful of how you do this. There are lots of things you could do. You could run it with an F and type an M back in and send that off, or and it really depends on your exact status. I come through my occupational medicine world, and some of our employers want the actual results, and so you have to, or required by regulation to have the actual results. And so if that's the case, then you just have to figure out how you're going to deal with that. But there is a confidentiality issue, so don't just change it. Make sure you talk to the patient about that and what you're going to do with that and how that might work out. I'm going to stop now because if I get the obesity case takes about 10 minutes or 15 minutes even. That's a long thing. I wasn't sure how much time I would have. So I'm going to stop at this point. Does anybody have any questions about any of the things? I know there's some chat stuff which I haven't seen yet. So I'm going to stop sharing for a second and see if anybody has any questions or thoughts on either the lobectomy or the gender reassignment.
Thank you so much, Dr. Wentz. I'm not sure if we had any questions come through just yet about the didactic, but absolutely, if anyone has any comments or questions, this is a great chance to ask Dr. Wentz.
So I'll ask, there was one question that was asked in the chat, which was the question was, does lobectomy the same thing as lung volume surgery, the lung volume reduction surgery, where they would excise the emphysematous parts on the top of the lungs? And that's a great question. I haven't looked at that. What I was talking about was if they take out the entire upper lobe or lower lobe, or I guess the middle lobe on the right, that would be that's what I was looking at. But whether lung volume reduction surgery changes spirometry is a great question that I don't know the answer to. I'll have to add that to my list of the way I think of this is anatomic changes and their impact on spirometry and how to correct for it. That's a great question. I don't know the answer. I think a lot of it probably depends on how much was removed. It clearly it should, if done well, improve the spirometry over what it was before they had the lung volume reduction surgery, but I don't know how it compares to normals. That's a great question.
Thank you. And I see, Grisan, you had raised your hand as well.
Yes, I raised the question because if one has emphysema and the upper lobe, which has emphysema, is resected, then there is a definite boost in for a period equivalent to lung volume reduction surgery. And there is literature on that. So if someone has lung suction, surgery, it may not, it only lasts for a certain number of years, I think up to 5 years. And then of course the numbers would go down again. But that's something to consider if you have a patient who's had a resection of the upper lung and has emphysema.
That makes perfectly good sense clinically. I mean, that's why we do the surgery, is to give people better air movement. And I said, it's not as, they don't take as much lung tissue as they would if it was a lobectomy. That's why I just don't know what the impact would be. But my guess is, and I'll have to look into this, but my guess is that has been studied. Certainly, and the trick for those folks is going to be seeing not just how they compare to themselves, which is unfortunately an awful lot of the surgical literature just compares somebody pre-op to somebody post-op without comparing them to population norms. But it'd be interesting to see how that compares that way. That's a great idea. I have not looked into that.
Dr. Wentz, I had my right upper lung totally resected, total resection. And I did have that bump for about 5 years. I've never completely lost it, but that's why it was attributed as it was.
Excellent. I'm glad that helped.
Thank you so much, Grace Ann, for sharing that with everyone. Any other questions or comments from the group? And Dr. Werntz, I know you said you had about 10 minutes more of a case. We actually do have 10 minutes left until 9 a.m. So you're more than welcome to jump into that, or we can always save it for next time, as well as maybe like a mock case that we can go over with the group.
Yeah, the only case part that I had was just the only case part I had was just the one that we already did with Dr. Doyle. So I do not have more case information. But the next one is it's the next anatomic abnormality, and I've got 6 of them. So, and it sounds like I need to have 7. So I'll be working on that. So we'll cover some of the other anatomic abnormalities in the future.
Absolutely. No, that sounds wonderful. And you covered a lot of ground there, so we appreciate it a lot. So I can give you all 9 minutes back to your Monday morning. If there weren't any other questions, I'll give it a moment here if there are. Okay, and if there are any questions after the fact, just shoot us an email and we'll make sure to have it addressed. I appreciate all of you with the great questions and discussion here. That is really what drives the ECHO session. So we're really happy to see that you all are enjoying the sessions and engaged. Dr. Doyle, thank you again for the case. Dr. Werntz, thank you for the awesome didactic presentation. My only announcement is that our next session will be on February 21st, and Dr. Sangani will be presenting on antifibrotic and coal mine dust lung disease. So keep an eye out for that reminder, and we'll see you all next time. Have a great week, everyone.